Hello and welcome to the April meeting for the Rural HPV Vaccination Learning Community. On behalf of the American Cancer Society and the National HPV Vaccination Roundtable, I want to thank you for taking time out of your busy schedules to join us today, whether that's live or via recording in the future. Today's meeting will deep dive into HPV vaccination data, sharing the ins and outs of national, state, and local data sources with you. Hi, my name is Ashley Locke. I'm an HPV program manager from the American Cancer Society, and I have the honor of talking with you first today, but I am part of a much larger team that encompasses many colleagues, both from the American Cancer Society and the National HPV Vaccination Roundtable, who work on increasing HPV vaccinations every day. To get us started, I just want to go through a few general housekeeping items with you. Today's call will be recorded and the video and slides will be shared afterwards via email and be posted on our website, which I'll reference later on in today's session. As far as our roadmap for today's call, in a few minutes here, you'll get to meet Dr. Robert Bernardchuk, who will talk through HPV vaccination data with you. We'll have a short Q&A with Dr. Bernardchuk, followed by an HPV vaccination panel made up of partners who have experience pulling HPV vaccination data. And then as we wrap up, I'll showcase some HPV vaccination data tools and resources with you. But before I do so, I just want to review some objectives. These should all look familiar to you as they were listed in our program overview. These will be our guiding principles throughout our 10-month journey together. It's our hope by participating in this learning community, you will see an increase on-time HPV vaccination rates, be able to build awareness around the importance of HPV vaccination data, expand knowledge around all things HPV, including infection, related cancers, and vaccination series, be able to discuss best practices and challenges, increasing HPV vaccinations in rural communities, and lastly, explore evidence-based interventions and practices to increase HPV vaccinations in your communities. Both American Cancer Society and the National HPV Vaccination Roundtable take a systematic approach to our quality improvement framework, and this slide in particular showcases the steps we our partners use to not only improve HPV vaccination rates, but also cancer screenings. Today, we'll begin by covering step 1 by assessing HPV vaccination data. So without further ado, I'm excited to introduce our first presenter for today's session. Dr. Robert Bernardchuk is an associate professor of global health and epidemiology at the Emory University Rollins School of Public Health. He is also faculty member of the Winship Cancer Institute Cancer Prevention and Control Program, as well as the Emory Vaccine Center. His research is focused on understanding the epidemiology of vaccine uptake and vaccine hesitance and developing and testing interventions to address vaccine hesitance. His work includes analysis of large data sets, including the National Immunization Survey and state-level immunization registry data. Without further ado, Dr. Bernardchuk.
All right, thank you very much, Ashley, and thank you for this opportunity to speak on this very important topic. Next slide, please. So my presentation today is going to be focused in on high-level rural HPV vaccination data, looking at multiple different data sources that may be able to be used to get a better understanding of this topic. Next slide, please. So just as a quick overview and reminder, every year annually in the United States, there's tens of thousands of HPV-related cancers that occur. HPV is responsible for 6 different types of cancers that occur in different anatomic sites across the body. Next slide, please. And when we look at smaller geographies, such as state-level incidents, we can get a better understanding of where we're at, both for states comparing to national levels and then even within states. So for the years 2016 to 2020 in the state of Georgia, where I'm located, there was an annual average of about 439 new cervical cancer cases. The age-adjusted incidence rate of cervical cancer in the state of Georgia is slightly higher than that in the United States overall, at about 8 cases per 100,000 women, compared to 7.5 per 100,000 for the US overall. However, if we look at more granular areas within the state, we can see that there's some areas primarily in the rural areas of the state, where incidence rates may exceed 9.5 per 100,000, or in some cases even greater than 11 per 100,000. So we need to be able to account for that heterogeneity in disease outcomes such as cervical cancer rates, but also when we think about vaccination and the way that we're doing outreach for vaccines in different areas in our geographies. Next slide, please. So today I'm going to talk about two main sources of data that can be used to try to understand vaccination coverage, and how they can be used to understand rural vaccination coverage. This is going to be the National Immunization Survey Teen, as well as a brief overview of state-level immunization information systems, also known in some cases as immunization registries. Next slide, please. So starting off with the National Immunization Survey Teen. Next slide, please. So NIS Teen is an annual survey that the Centers for Disease Control and Prevention has been conducting since 2006. It starts off with a random digit dial survey. Currently, only cell phone numbers are included in the sampling frame for the survey. In the past, there was a broader outreach to landline phones, but now there is a focus only on cell phones. The target population for the survey is parents of 13 to 17-year-olds. And for individuals who do receive a phone call for this, the general procedures for NIS Teen are to conduct an interview with the parent or guardian of the eligible teen. And then at the conclusion of that interview, which measures a number of different demographic characteristics, recall of vaccination status, et cetera, permission is sought to verify the child's vaccinations with their healthcare provider. Then if that permission is granted and the providers are able to be reached, provider verified vaccination status is verified, and that's where the national and state level vaccine coverage estimates derive from. So annually, there's about 15 to 20,000 teens who do have provider verified data in each year's instance of NIS Teen. And this data is weighted to national level population estimates. Now, that 15 to 20,000 sounds like a large number, but when we start thinking about smaller geographies like states, if you think about this in terms of 50 states in the United States, now you're looking on average between 300 to 400 teenagers per state. So that does limit our ability to do more granular types of data analysis. Next slide, please. So again, within the National Immunization Survey, there's two main surveys that are done, the NIS Child and the NIS Teen. Information here does show how more detailed information can be obtained about these surveys, including access to publicly available analyzable data that can be used for evaluation purposes at different levels. And again, as mentioned in my introduction, this is an area of analysis that we use very broadly in our team. There are a number of interactive data visualizations that are based off of the NIS data collection and other data sources looking at vaccine coverage. These are all available at the link shown here, but they do encompass the childhood vaccines, adolescent vaccines, adult vaccines, flu vaccine, COVID vaccine, and then also vaccines at school entry, at kindergarten entry. Next slide, please. So if we look at data from TeenVaxView, which I mentioned on the previous slide, we can see vaccine coverage for adolescents in the US. And these are figures that any of us who work in the area of adolescent vaccination are very familiar with. We see high coverage of quadrivalent meningitis vaccine and Tdap vaccine among adolescents. We see much lower coverage of HPV vaccine uptake in that same population. So this does show us something that we've been aware of, is that adolescents do go to the doctor, they get some vaccines, but they're not always getting HPV vaccine. But again, these estimates are national level estimates. Next slide, please. So there is data that is collected on rurality and urbanicity in the National Immunization Survey, with residents classified as living in a metropolitan statistical area principal city. So for example, myself, living in Georgia, living in the Atlanta metro area, and I live actually in the city of Atlanta, so I would live in an MSA principal city. There's also MSA non-principal cities, which are more of the suburban areas outside of the main cities, and then non-metropolitan statistical area residents, which are primarily our rural locations. Data aggregated over the years 2018 to 2022 is shown here for adolescent vaccine coverage, stratified by these measures of urbanicity. And we can see that over these 5 years of data that are aggregated together, we've got about 36,000 kids who live in main cities, about 38,000 living in suburban areas, and about 17,000 living in rural areas. So again, we are able to get national estimates accounting for some of these areas of residence, but it will be, again, limited to a certain extent by sample size. We can see that overall, while there's very minor disparities for meningitis vaccine and Tdap vaccine by rurality, especially for Tdap vaccine. We do see much larger differences comparing MSA principal city residing adolescents to non-MSA residing adolescents for HPV vaccine, shown as the deeper green and teal bars in the right two sets of graphs here. So we do have some ability to look again at these issues of rurality, again, at a national level. Next slide, please. Now, if we take this same National Immunization Survey data that's visualized on TeenVax View for the state of Georgia, we can see a little bit more variability in the vaccine coverage estimates. And this doesn't necessarily mean that vaccine coverage is dropping over time, in appreciable levels. This may just be due to some of the sampling and the uncertainty around small sample sizes per year per state. So we do need to take some of these state level estimates and put them in that appropriate context there. Next slide, please. Similarly, we can look at 5-year aggregate adolescent vaccine coverage stratified by rurality in the state of Georgia. And now here you can see that the total sample size for those 5 years of data is only about 1,500 adolescents. So these estimates are going to be very imprecise. But we can see some patterns in here where we do see lower vaccine coverage in both suburban and in rural areas compared to people living in MSA principal cities, primarily for HPV vaccine. But again, these estimates that we see here would be associated with very wide confidence intervals due to a lack of precision from a very small sample size. Next slide, please. So I mentioned that NIS teen data can be accessed and used for analysis purposes. The website that's shown here, that's linked at the bottom of this slide, can take you to links for the raw data files as well as standardized input programs for both analysis using SAS or R. There are data users guides available that contain all of the background data, the sampling weights, all of the information that's needed to contextualize this information, as well as any changes in data collection over time. These data are publicly available de-identified data. So these types of secondary analyses are typically not considered human subjects research because there is no way to link individual data elements that are in there to individual persons, at least for the publicly available data that individual researchers can use that are linked through this website. Next slide, please. So doing analysis with this NIS teen data does have to account for a number of issues. First off is that the NIS teen is a complex probability weighted survey that utilizes cluster-based sampling. So for this, if you are doing data analysis on that, there are specific There are specific analytic procedures that have to be used to account for this complex survey analysis. It's also important to know that that household survey that's initially conducted before the request for provider immunization record checks, typically we see about 50% of respondents to the household survey do end up having children in NIS that have adequate provider data available. So when CDC publishes their analysis every year of vaccine coverage data, that is restricted just to this provider verified data, but the household survey data is available for analysis of the parent or guardian provided data. NIS teen does have a fairly large sample size. So in 2021, there were about 45,000 adolescents that were contained in the NIS teen, of which about 40% had adequate provider level data. So if you look at state level sample sizes for the provider level data, we can see that those range from about 191 to 857. So again, very small sample sizes per state, which can make it difficult to do further analysis by sociodemographic characteristics. Next slide, please. And this just shows some of the previous work that we've done within my team using NIS teen data. As these slides are made available, all of these papers are linked there to see some of the breadth and depth of the types of analyses that we have done historically. Next slide, please. So now I would like to shift a little bit to talk about immunization information systems, IIS, also known as immunization registries. So each state and some sub-state jurisdictions have an IIS. So for example, in New York State, there's the New York State Immunization Information System, which encompasses vaccines that are delivered in New York State outside of New York City, but New York City has its own immunization registry. So some separate immunization programs do have separate IIS. This is important because the reporting requirements, the data sharing requirements, inclusion criteria are all determined by the individual jurisdiction. There's much more information available about the different IIS and all of these different regulations and requirements associated with them at the CDC website listed here. Next slide, please. So in the state of Georgia, we have the Georgia Registry of Immunization Transactions and Services, also known as GRITS. This is our statewide immunization registry. And for this registry, the reporting requirements indicate that any person who administers a vaccine or vaccines licensed for use by the US FDA to any person in the state of Georgia must report that vaccine to GRITS. Now, there are some limitations to that in terms of providers who may not be in the GRIT system. We also have to be considerate of maybe children who live close to a state border and seek care in a different state. That data may not necessarily be transferred over into GRITS. Work that we've done has been done with individual level data that has been requested from the Georgia Department of Public Health, and that's going to be what's underpinning some of the data that I'll show in a minute. Next slide, please. So some strengths and limitations, and again, this is specific to GRITS. There will be different strengths and limitations for different IIS and different jurisdictions. GRITS does allow for bidirectional data transfer. So if one provider provides a vaccine and records that in their EMR, that information can be transferred from the EMR to GRITS, but also EMRs can pull down GRITS data so that if there is a different healthcare provider where care is being sought, they can still see all of the GRITS recorded vaccines for that individual patient. Because all vaccines are supposed to be reported in GRITS, it is ostensibly a cradle to grave vaccination record, though we do see that we do have much more complete data available for children and adolescents. There is granular data on individuals by birth date, by zip code of residence, race and ethnicity, very granular level data on vaccines, vaccination lot numbers, vaccination type, the facility where the vaccine was given, et cetera. And because individuals are maintained in the system, we do have the ability to conduct longitudinal analysis, for individuals to track their vaccine uptake over time. A few key limitations that we've seen in GRITS is that the data that's stored in there is numerator-only data. So we have good records on all of the vaccines that were administered, but we still need to get the underlying population levels to account for that. So oftentimes we will link that to census data. There is census data that's available stratified by time period, age, county of residence, race, and ethnicity. So we've been able to use that for denominator data. One other thing that we've identified is that there are some areas with high levels of missingness, particularly for race and ethnicity. And for some of the analyses that we've conducted, we found about 10% of adolescents missing race data and about 35% missing Hispanic ethnicity data. So this is work that we'll be reporting back to the Georgia Department of Public Health to help with their outreach to providers around data completeness. Next slide, please. So as I mentioned, the data in GRITS is longitudinal, and this is an example of some of the analysis that we've done where we took a one-year birth cohort of adolescents who turned 18 coming up into July 1st of 2017. You can see here the first red dashed line that indicates when these adolescents turn 9, so it starts the eligibility for some of the adolescent vaccines. And we have different combinations of vaccines that were received. So the legend on the side there, P stands for pertussis, so that was the Tdap vaccines. M stands for meningitis, so it's the quadrivalent meningococcal vaccine, and H for HPV. You can see that the Tdap and meningitis only receipt, which is shown in orange, does increase very rapidly after adolescents turn age 9, and it does start to drop down a little bit. And that decline is in part due to the increase shown in the dark blue line, which is the proportion of adolescents receiving all 3 adolescent vaccines. So here we're able to see that there are some adolescents who got their Tdap and meningitis vaccine who didn't get HPV vaccine initially, but then did get it at later ages. So they shifted which category they were in. So again, this is helpful for us to identify some of these patterns over time in vaccine uptake. Next slide, please. We've also conducted analysis by sub-state geography, and the 3 maps that are shown here represent, again, different combinations of adolescent vaccines. Now, these data are data through 2017, so the vaccine coverage estimates may be a little bit lower than what we've seen in more recent years, so just keep that in mind. But map A represents the proportion of adolescents who received the Tdap vaccine and the meningitis vaccine and the HPV vaccine. Darker shading indicates higher vaccine coverage. Map B represents the proportion of adolescents who received Tdap and meningitis vaccine, but not HPV vaccine. And map C represents the proportion receiving no adolescent vaccines. Now, interestingly, in map C, we can see a few areas with higher proportions of adolescents not receiving any of the vaccines. Those are primarily rural areas in northeastern and southeastern Georgia. But most interesting to us was Health District 5-1 in the kind of southeastern, central southeastern area of the state. And that's the dark blue health district that is shown in map B. And what's interesting to us is that in this health district, we're not seeing a high proportion of adolescents that are fully vaccinated. We're also not seeing a high proportion of adolescents getting no vaccines. So to us, this is probably a marker of HPV vaccine-specific hesitance. So this is an area where we're preparing to do some more targeted outreach, working with our cancer center to try to understand exactly what's happening in that particular health district, which again is a much more rural area. But using this immunization registry data does give us the ability to dig a lot deeper into vaccine coverage. And the data that we have here, which goes from 2006 to 2017, represents about 1.4 million adolescents. So before, when we were talking about the range of 1,500 adolescents in NIST over a 5-year period for the state of Georgia, here we've got in the range of close to 1.5 million in an 11-year period. So we have much greater ability to do some of these deeper analyses. Next slide, please. So why did I spend so much time talking about Health District 5-1 and the potential for HPV vaccine-specific hesitance in there? Well, if we look at incidence rates for cervical cancer in the state of Georgia, you can see that geographically there is a similarity that that health district is also seeing some of the highest cervical cancer incidence in the state. So now this is really giving us an indication of higher levels of underserved populations, where they may not be undergoing cervical screening as well as may not be receiving HPV vaccine. So this really is a priority area for outreach in terms of trying to address HPV related cancers. Next slide, please. So in summary, there are a number of different data sources that can be used to look at the geographic distribution of HPV vaccine uptake. Each of them have their own strengths and limitations, so that does need to be considered in there. Working with state departments of public health and immunization registry teams to identify paths for data analysis or data access can help support some of these activities. This is work that we've been doing at Emory to be able to take on some of the heavy lift of some of these more in-depth analyses over time. And recently, I just published a commentary talking about the need for looking at more granular vaccine coverage within states. So hopefully this can be a little bit of a call to action for all of us who are working in the immunization world to be able to find new avenues with which to be able to do some of these analysis. Again, this is something that I've been doing for a number of years. It's work that we're doing with the National HPV Vaccination Roundtable and the Best Practices Task Group in terms of looking at data sources. And I am happy to make myself available if there's assistance needed in trying to understand this a little bit more deeply. Next slide, please.
Perfect. Well,
Thank you.
thank you so much again, Dr. Bernardchuk, for your experience and for sharing all of the knowledge that you have about HPV vaccination data and really walking us through the different sources. So I do want to take a couple of minutes and do a quick Q&A. So a couple of questions for you. In your experience, how has HPV vaccination trends, changed over the last decade?
Yeah, so I think with HPV, we have seen, we've seen good increases, not to the same level that we see with the other adolescent vaccines, but we haven't seen it increasing over time. But again, most of those estimates are coming from larger aggregate estimates. So say from National Immunization Survey, so we can look at state level, so it makes it a little bit more difficult to look at some of those state level trends as I showed. I think that as we start taking a deeper dive into some of these data, we can understand a little bit better where there may be outliers to some of the trends, where we have seen some of those increases. So again, we can do a little bit more directed outreach and engagement to work with communities that may not be seeing that same level of increase in vaccine coverage, so that we can try to put all of these efforts together towards the prevention of HPV related cancers.
Perfect. Where do you see the biggest variance when it comes to HPV vaccination data? So, like, I guess, for example, gender, ages, geographic.
Yeah, so I think, in terms of gender, we've seen a lot of those gaps close over time. Initially with HPV vaccine being recommended initially for girls in 2006, and the recommendation for boys in 2011, there was a little bit of a time lag in there. A lot of that has really kind of closed down over time, and even CDC has moved towards reporting it as just an aggregate estimate now. So I think that's a little bit less of a concern. Interestingly, with NIS team data, we see disparities that look very different than what we see for other vaccines, especially for initiation of the HPV vaccine series, where we typically see higher vaccine uptake among racial and ethnic minorities compared to white adolescents, and also for adolescents living below the poverty line compared to those living at or above poverty. So this is, an area that we're looking at that, it may be an access issue. We know Vaccines for Children has done a great job in reducing disparities, but there may be, other behavioral aspects in there. So that's an active area of research and trying to understand that. But now that we've got more data on rural areas, this is really a big focus area of some of the work that we're doing to try to address some of these intrastate disparities that we may be seeing, to make sure that we're not leaving behind any of our rural areas.
Perfect. And then one last question from your perspective, what are some tips and tricks we should consider as we begin, looking at our HPV vaccination data?
Yeah, I think really the biggest thing is partnerships. I've been working with immunization registry data since I was a doctoral student in 2009 and 2010. So this is, this is work that I've been doing for a long time. Even some of that initial work that I did in New York State, for example, really took a lot of time to establish these academic and public health partnerships to grant us access to the data, to be able to work with that. We've seen some of that similarly, that need for strong partnerships here in Georgia. So I think having good linkages between community partners, between academics, where again, we may have a little bit more of the time and maybe some of the advanced analytics expertise in there, and the public health departments, to really make sure that everybody is on the same page, and doing that upfront work before diving right into the data is really, really important for establishing the proper context for that.
Perfect. I love that partnership. So I want to thank you again for joining us for today's session and helping us to really set the stage for HPV vaccination data. So we are now going to turn over to our panel, which I'm very excited to introduce. Um, so we have a wonderful panel of speakers who are going to share their knowledge and experience pulling HPV vaccination data with us. I'm going to quickly introduce our panel and then we'll go ahead and get started. So please welcome Vicki Johnson. She's the Regional Site Director of McKinney Operations at Community Healthcare Center in Texas, and Dr. Gretchen Jones, Patient Transformation and Practice Integration RN Coordinator at Catholic Health Initiatives. So I'm going to stop sharing my screen so we can go into gallery mode here. And Vicki, I would love to start with you if you could share what data source you chose and why.
Thank you for that question. The data source that we use for patient data is Azara. It is a population-based software that we use, and it has some excellent features to be able to drill down to very granular data, such as zip code levels, geographic spacing. We can also look at things like race and ethnicity. We can also look at, age characteristics and gender characteristics. So it's a wonderful feature that we have available to create registries where we can actually drill down and look at that data and see how we're doing, because it not only detects the numerator data, but it also collects the denominator data. So it's been a really great thing for us to be able to see over time, and that software has been very helpful for helping us to increase our vaccination rates.
Perfect. And then Gretchen, which data source did you choose and why?
So our data source is, we use Epic, which is our EHR. And with that, we also have the ability to pull in from NISIS, which is the Nebraska State Immunization Information System. So if we have patients that have an immunization outside of our system, that will get pulled in for us. And the way that we have it set up, as I pull a report, I can look at how many doses they've had, age range, all of that information I can pull into a single report to see how we are doing with our immunizations.
Perfect. So as much as we've chosen our data sources, I know that there's also challenges when it comes to pulling HPV vaccination data. So, Vicki, I don't know if you want to share some of the challenges you experienced when you first started pulling your data.
Yes, one of the first challenges that we experienced had to do with mapping. Anytime that you're using any kind of reporting software, you have to make sure that the codes are mapped. You have to make sure that all that is validated. So that was probably one of the biggest challenges, to make sure that that was completed and validated. And then also utilization of the software itself, because there's a pre-visit planning module that's also included in that software. And utilization was a big challenge for us. So one of the things that we had to really make sure that people understood was not just the fact that they needed to use the software and what it was capable of, but why. understanding the why is so important when we're implementing these software programs.
Perfect. And then Gretchen, what about you? What challenges did you experience?
The biggest challenge that I found when I started to look at our data is our columns were not built out the way that we would have hoped. So I could pull data through 13 years old, but anything above 13, we could not pull in to see if patients haven't been immunized for HPV, how many doses they've had. Any of that information was not pulling into the report. Um, and that's a big deal because we do know that there is that catch up through 26. There is the ability to have the immunization from 27 to 45 if you're discussing it with your provider. So being able to look at that and see those different age ranges was very important to us.
Perfect. Both of you kind of talked a little bit about this, but um, when planning to pull data, who else should you loop in? So what other staff should be considered as you're kind of pulling this? And I don't know, Gretchen, if you want to start first and then Vicky.
Yeah, so one of the things that we do is we get input from um, our actual clinical um, staff, whether that be providers, our clinical support staff, so our MAs, RNs. Um, and then I also utilize the data analyst on our team because she can help me just really focus in on what we're looking for. So making sure that we just have a variety of people um, that have that buy-in to be able to know that we're pulling information that is going to be useful for everybody.
That's a great point. Vicky, what about you?
Yeah, I would like to add to that. So we also involved our chief medical officer. We felt that was a really important person that really needs to be included in this because she's given the standing orders, she's given the directives, about what the expectations are as far as administering the vaccine, the age groups that we're targeting, that kind of thing. So getting the chief medical officer involved was a very important step for us. Another one was we got the director of nurses and her staff, especially her trainers, because they were really important people to get involved in this because again they're the ones who are out there and out there in the trenches, I guess you could say, but they're the ones who are actually doing the administration of the vaccine. So understanding their documentation processes, understanding how they're pulling their information to know when a person needs to get the vaccine. So those are things that we felt were really important, is to get those people involved. The data analyst that you mentioned, Gretchen, also is important because they can understand how to get into the data and actually how to pull it. I actually serve as part of that function in our organization. So understanding that was a really big thing for us, and really working through those processes to make sure, again, going back to the mapping, that everything is mapped appropriately, and that we could pull the data that we were actually needing and getting the feedback that as to understanding why that data looked the way it did. Those would be my recommendations.
Perfect. So I know both of you are really far on your HPV vaccination data journey, but kind of looking back, what would you tell your past self about starting this process? So I don't know, Gretchen, if you want to go first, and then Vicky.
Yeah, so I would probably tell myself that to be patient. Um, you know, we kind of sometimes have this expectation that things just need to be instantaneous, especially, as we're trying to work on something. And when you're trying to get something built into your system, even if it is a column in a report, um, it can take a little while to do that. So I think patience is the biggest thing that I would tell myself.
That's a great point. What about you, Vicky?
I think one of the things that I would say to myself, again, like you said, Gretchen, is patience. But the second thing is is don't give up and remember to test your data and test changes. We use PDSAs all the time. And this is something that you should get really good at, is doing those PDSAs, because you can make small changes over time and test those small changes and see if you're getting the results that you're wanting. If you're not, go back and test it again and just keep doing it over and over and over until you get the desired result.
That's a really great point. We're actually going to talk about PDSA cycles in future calls. So I appreciate you bringing that up. When thinking about HPV vaccination data, are there any resources or tools that you would suggest using? Vicki, I'll go with you first and then Gretchen.
Yeah, so with regard to PDSAs, one of the things that we have found helpful is to use the PDSA tracking tools. And those are really, really helpful. But there was a tool that was given to us when we first started the HPV project a few years ago. In that project, there was a worksheet that we were given. The American Cancer Society actually provided it to us. And it was able to break down that granular data. It was really, really, really helpful. And I still use it. So that is something that I would recommend, because you can see over time what that looks like, and you can also capture patient stories and what have you. So I think that's real important to use those tools that are evidence-based.
Perfect. What about you, Gretchen?
Can you repeat it? Because my
Oh, yeah,
brain's going
absolutely.
crazy.
What resources and tools would you suggest using?
Oh, yes. Okay. Um, so for the way that we have our system set up, everything is in our EHR, which is extremely, extremely helpful. So one of the things that we try to tell our clinics is really utilizing the reports that we have. Um, and this is something new for us, but we have an immunization dashboard for our pediatrics and adolescents. And that has been almost a year in the making. I've been working with our Healthy Planet team to create that. And having that type of resource where I can go in, or a clinic can go in and look at their specific clinic data on their immunization rates, and they can filter that down in their own report, has been, and well, I can't say has been really helpful, but it will be really helpful. I've gotten a lot of really positive feedback from the little bit that we've been able to do with that dashboard right now. But having easy, accessible ways to get that data, for those that are doing the immunizations, the ones that are in direct contact with the patients, is important.
I would like to add also that
Yeah.
the Azara population software that we're using, that population management software, it does connect directly to our EHR. And so one of the things that's really nice about it is, again, going back to this tool of that pre-visit planning module that we have, that has been extremely helpful because it tells what immunizations are due. It tells if they're overdue. I mean, there's all these things that it does for the person there at the time of the visit or right prior to the visit, which is fabulous. And it updates daily. So we have real-time data that we know what we're dealing with. So that's been a very, very useful tool for us. And you mentioned the dashboards. This visualization from the dashboards is just a phenomenal thing where people can see firsthand what's happening. And when you've got a system that you can see that weekly or monthly or quarterly, it's a really nice feature to be able to see that. So
Yeah. And again, being able to pull reports from that information, I think, is very helpful too. Um, because you need to be able to drill down on that. It's great if you see that, 50% of your patients are up to date, but if you don't know which patients those are, um, you can look at each individual patient, right? But how do you work on outreach then? Um, so those reports really do help with outreach as well.
That's a great point. And to both of you, so I know Vicki, you had mentioned, using visualization, which is really important, especially as you're, training staff, and different staff learn different ways. Like being able to visualize it sometimes helps them to better understand, what the data means. And to your point, Gretchen, I think, having these tools available will also help with some of the interventions, right, that our partners will take as they're kind of looking through their HPV vaccination data. So another question for you guys, how do you use the data to inform your next steps? And I'll go with Gretchen and then Vicky.
So the way that we utilize that data is um, we can look and see which of our clinics are doing well, which of our clinics are not doing as well. And we can tailor education around that. We can also talk to those clinics that are doing really well and say, what are you doing? How are you getting patients in? What happens within your clinic that your numbers are so high for your patients? And I think that's really helpful to bring those different ideas to those clinics that maybe aren't doing as well. Um, and, then as we're trying to help those clinics that maybe have really low numbers, we can utilize some of that information from those top performing clinics um, to help improve those, maybe that are struggling more.
That's really great. I love that. What about you, Vicky?
So I would like to take it a step further than that. Not only can we use this data to inform best practices within the clinics, but also I think it gives us an opportunity to use that information to go out to our external partners and talk about, okay, so like in the schools, let's look at this data. How can we help the schools to really to look at their policy, right? Because school policies don't require HPV vaccine. And so how can we use that to formulate better partnerships to help to expand this beyond the clinic status, but also thinking about it from a state level, thinking about it, okay, how can we take this to a state level and advocate for new policies about HPV vaccine to where it is required or mandated in the schools, so just really working with those external partners, to understand how this data impacts patient care, but also how it impacts patient outcomes. And if we can focus on this as a cancer prevention in our advocacy, then I think that using this data is one way to do so.
Perfect. And that kind of goes to Dr. Bernardchuk's point, which is, partnerships are key, especially when it comes to HPV vaccines. So one last question for you both. I know many of us don't have a strong background in data. So what is the best way to interpret HPV vaccination data? And I'll go Vicky and then Gretchen.
Okay, what I would like to say is think about proportions. I think it's really important that you don't just look at the numerical data, but look at the proportions. So for example, in our clinic, our rates, you may think, well, you only had a 2% increase. But when you look at proportions, you have to think about how many new patients came into the system that you've not touched prior to this, right? And so how many new patients are coming in. So you have to look at proportions. Don't just look at just the raw numbers, look at your proportions, right? Because you may see that. So for example, if you see a 2% increase in your rate, if your 2% increase over time, your proportion may have been much more than that. So just think about those in terms of don't just look at raw numbers, don't just look at percentages, but look at proportions, because that's going to tell you a bigger story, and look at it over time.
Perfect. And Gretchen?
I also think I completely agree with Vicky. Looking at proportions is really, really important. I also think that we need to look at, are we seeing trends anywhere in that data? So, I work with about, I think, 43 clinics in Nebraska and Southwest Iowa. Are we seeing trends where our rural clinics have lower numbers? Is our inner city clinics having lower numbers? Or, are they having higher numbers? Um, do we see demographically, certain races or ethnic groups having differences in numbers? Do we need to, because that does allow us to tailor then our education that we give. So while we can look at those proportions, I think that you adding in some of those little extra steps um, to really break down that data is important as well.
I would like to add one more thing too, and is if we break it down by zip code,
Mhm.
zip codes are a significant predictor of health outcomes. So I think if we can look at it at the zip code level, that is granular data that we can use to, again, target those interventions. And if we're going to educate, if we're going to do outreach, let's focus on those ones where those rates are the lowest.
Mhm.
Because guess what? You can go out there, you might be able to do mobile clinics out there. You might be able to do different things that can help to bring that to them as opposed to them having to come to you.
Yeah, and I will add this just because I don't know if it's happening in other places, but we do have to really work at combating, misinformation that is out there around immunizations. Um, and what we are finding in our area is there is an anti-vaccine group that is sending stuff to the schools. Um, so, being able to find out, maybe those areas that are lower are getting and trusting that other information that is out there. Um, but I think that also goes back to when Vicky mentioned those collaborations with other organizations, um, really finding out, are they getting some of that, and really working with them to try and combat that. Um, I know that's a little different than data, but I want to throw that out there because it's a huge thing in our area right now, and other people might be seeing that in their area as well.
Yeah, no, and I think that's a really great point. And to almost to Vicky's point is if you are looking at zip code data, is there an anti-vaccine group within a zip code that maybe you can draw some conclusions to? So that's really great information. I really appreciate both of you guys being a part of today's panel and sharing your insight and your knowledge. You both are wonderful HPV champions and data champions. So I appreciate you being here and sharing that with us. We are going to conclude today's session. Um, so I shared during our kickoff call, but want to revisit our external facing website that we've built for all of our participants in the rural HPV vaccination learning community to be able to access all the resources shared during our 10-month journey. So this will include recordings and slide decks from our monthly sessions. On the top of the page under important links, you'll see we have placed important documents like our program overview, the registration link, both the American Cancer Society and the National HPV Vaccination Roundtable's parent and patient-facing resources on HPV vaccines, which we hope you'll review before our May session. And we've also pinned a document that houses our monthly recordings and slide decks. Additionally, as you scroll down the page, you'll see more information on the learning community. We've also pre-populated the website with resources, like I said, on patient and parent education materials. We've included some clinical education materials where you can find continuing education opportunities for clinical staff, for pharmacists, and even dental professionals. And we've linked some of our quality improvement resources, which we provide to our partners. And I've actually added a resource on HPV vaccination data definitions. So if you need assistance on pulling HPV vaccination data, this document goes step by step on how to pull your numerator and your denominator for those different age groups, looking at genders, and even comparing them to other adolescent vaccines like Tdap and Menenge. And we use these data definitions with our partners who do those formal quality improvement projects with us, International Prevention and Screening Cohort. And this in particular just reviews our curriculum schedule for the next couple of months that we have. So we will be meeting again on May 22nd, and we're going to hear from Dr. Lindy McGee on HPV vaccination starting at age 9. I know age 9 is a very hot topic now. Additionally, I do want to note, I noticed that our calendar series did not populate for August, November, and December. So please look for our calendar invites following today's meeting. And our call to action for our group is please, review our website. If you haven't done so already, please make sure to bookmark it for future use. Review that data definitions document. And then in preparation for our next month's session, please explore your organization's readiness to start HPV vaccinations at age 9 as well. Look at those materials that I referenced. So the American Cancer Society and the National HPV Vaccination Roundtable both have patient and parent-facing materials that are available to you. As well, the HPV Vaccination Roundtable has put together a really great collection of research articles that talk about age 9. And lastly, we would love to hear from you and for you to share how today went, what you liked about it, what could go better. So we'll share a link in the chat for our survey as well. I will also include in our follow-up email. So let us know what you want to learn for future sessions. We'd love to hear if you're interested in sharing a best practice or a challenge. And we really want to make this learning community a positive experience and keep it relevant to each of you. So thank you again for participating in today's session. Thank you to our panelists and to Dr. Robert Bernardchuk for participating. And we look forward to seeing you on May 22nd.